Welcome back to the Deep Dive. Today we're taking a shortcut to some really fascinating high-level medical insights. We're looking at how cancer can show up in ways you might never expect, totally separate from the actual tumor.
That's right. We're focusing on paraneoplastic syndromes, or PNS for you. Basically, these are clinical signs and symptoms that pop up far away from the primary cancer or where it's spread. It's not the tumor physically being there, it's acting more like a distant chemical factory. It pumps out substances, hormones, maybe peptides, sometimes autoantibodies that just wreak havoc system-wide.
And the really wild part is the surprise factor, right? Like a skin issue or muscle weakness, or maybe a hormone imbalance could be the first sign, the very first clue that there's an underlying cancer, maybe months or even years before you'd find the tumor otherwise. Let's maybe start with how these tumors can act like rogue hormone factories. That seems pretty incredible.
Yeah, let's kick off with endocrine PNS. It really shows how versatile these tumors can be, biologically speaking. A classic example is ectopic ACTH syndrome. It basically paints the picture of Cushing's syndrome, CS.
Okay, so ACTH, that's normally the pituitary gland's job, right? Controlling stress hormones.
Exactly. But here you have a cancer cell which has absolutely no biological reason to suddenly deciding to churn out ACTH.
And which cancers usually do this?
The big one is small cell lung carcinoma, SCLC. It's responsible for maybe up to 3/4 of these ectopic cases. But here's the really crucial clinical difference, the thing to watch for. Because the tumor pumps out ACTH so fast, so aggressively, these patients look very different from someone with standard Cushing's.
How so? Because you usually think of Cushing's as, gradual changes.
Right.
The round face, the fat pad on the neck, the truncal obesity.
Right. But with the ectopic kind, the hormone levels shoot up so quickly, the body just doesn't have time for those physical changes. Instead of that slow buildup, you get an acute metabolic crisis. So these patients often show up really sick with things like severe hypokalemia that's super low, potassium metabolic alkalosis, sudden high blood sugar, and just profound weakness.
Okay, so the speed is the giveaway. A doctor sees someone acutely ill, metabolically unstable, but without the classic Cushing's look. That immediately makes you think, could this be a fast-acting cancer source?
Precisely. It completely shifts the focus from, say, an endocrine problem to potentially an oncology emergency. And tumors are quite good at mimicking other endocrine functions too.
Like messing with electrolytes and fluid balance.
Yep. Hyponatremia, low sodium is common, again, often linked to SCLC. The tumor makes too much antidiuretic hormone, ADH, so the body holds on to excess water.
Okay.
Then there's the flip side, high calcium or hypercalcemia.
Right. Which cancers tend to cause that, and how do they do it?
Hypercalcemia often pops up with squamous cell carcinomas, think lung, head, neck, but also kidney, breast, and ovarian cancers. The mechanism here is the tumor making something called parathyroid hormone-related peptide, or PTHrP.
So it's like the tumor is forging the signal, producing something that looks enough like parathyroid hormone.
Exactly. It tricks the body.
Tricks the body into thinking the parathyroid glands are overactive, telling the bones to dump calcium.
You got it. All completely independent of the actual parathyroid glands. It's really quite remarkable that a lung tumor, for instance, can pull off this specialized endocrine function.
It really is. Okay, so that's hormones. What happens when the cancer triggers like an internal civil war, when the immune system gets involved?
Ah, right. So now we shift gears to the nervous system, neuromuscular PNS. Here, the issue is often autoantibodies. The immune system sees something on the tumor it doesn't like, creates antibodies, but then those antibodies mistakenly attack parts of the nervous system or interfere with muscle function.
And the two big examples here are Lambert-Eaton myasthenic syndrome, LEMS, and myasthenia gravis, MG.
Those are the key ones. LEMS is very strongly linked with SCLC. That same lung cancer keeps popping up, doesn't it? It's a very biologically active tumor.
It seems so. And MG.
MG is more often associated with thymoma, a tumor of the thymus gland. And crucially, how they work is different, which helps tell them apart. In LEMS, the antibodies go after calcium channels on the presynaptic side of the nerve terminal before the signal jumps the gap.
Okay, so the nerve struggles to release its chemical messenger.
Right. Whereas in myasthenia gravis, the attack is on the postsynaptic side. The antibodies block the acetylcholine receptors on the muscle itself.
So LEM is like a problem sending the message. MG is a problem receiving it.
Nicely put, yes.
But the really clever diagnostic clue, the thing that's maybe the big takeaway here, isn't just the mechanism, it's where the weakness starts and how it spreads, isn't it?
Absolutely. This is often the aha moment clinically. It can really help sort things out. With myasthenia gravis, the weakness typically starts high up. Ocular muscles, double vision, droopy eyelids, that's over half the cases. Or bulbar muscles, trouble swallowing or speaking. The weakness then tends to spread downwards, what we call craniocaudal, head first, then down the body.
Okay.
And if you see weakness only in the arms, that points more towards MG, not LEMS.
And LEMS is the opposite pattern.
Pretty much the mirror image. In LEMS, the weakness overwhelmingly starts in the limbs. Like 95% of patients, their first symptom is weak legs or arms. Ocular onset, like the droopy eyelids, almost never happens first in limbs. And the spread is caudocranial, starts low and moves up.
Wow. So just asking, did your eyelids droop first or did your legs feel weak first can make a huge difference.
It's a powerful differentiator and super important because LEMS sends up a huge red flag specifically for small cell lung cancer.
Okay, so we've got antibodies hitting the nerve muscle junction. What if they target the brain itself, specifically the cerebellum?
Right, that takes us to paraneoplastic cerebellar degeneration, or PCD.
Sounds like it causes problems with coordination, balance.
Exactly that. It's an immune attack, often driven by specific antibodies like anti-Yo, that targets the Purkinje cells in the cerebellum. Those cells are crucial for coordinating movement.
And which cancers are linked to PCD?
Most often, breast cancer and pelvic malignancies like ovarian cancer. But again, SCLC can do it, and also Hodgkin lymphoma.
What would someone notice first?
It often starts with an unsteady gait, maybe some double vision, trouble with fine motor skills, think buttoning a shirt, handwriting. But the concerning thing is how fast it can progress. Over weeks or maybe months, it can lead to severe ataxia, where people lose coordination in their limbs and trunk. The speed is a real warning sign.
Okay, let's shift to maybe one of the most visually striking syndromes, the skin manifestations. Paraneoplastic pemphigus, PNP.
Yes, PNP is thankfully rare, but it's a really severe autoimmune blistering disease, and often fatal, unfortunately. Unlike some others we've discussed, PNP is most strongly tied to blood cancers, lymphoproliferative disorders, things like non-Hodgkin lymphoma, chronic lymphocytic leukemia, CLL, and Castleman disease are the big ones. Thymoma can also be associated.
So if the skin and the mouth are blistering apart, what exactly are the antibodies attacking?
They're going after proteins that act like, well, cellular glue, proteins called envoplectin and paraplectin, which normally hold skin cells together. When the antibodies disrupt these, the layers separate, causing these awful blisters and erosions.
And clinically, what makes PNP stand out? Are there unique features?
The most consistent and often the earliest sign is severe stomatitis, really painful, often bleeding erosions inside the mouth. It can spread all over the tongue, the inside of the cheeks, the lips. Very hard to treat. The skin blisters themselves can look like lots of different things. They're very polymorphic, sometimes like regular pemphigus, sometimes like bullous pemphigoid, sometimes even like lichen planus.
That sounds incredibly painful and dangerous just from the skin perspective. But I remember reading the mortality rate is extremely high, and not always directly from the skin issues.
That's the really critical point here. The mortality is devastatingly high, 75%, maybe even 90%. And while the skin disease is bad, and infection is a risk, the main driver of mortality is often respiratory failure.
Respiratory failure from a skin disease.
Yeah, it's because the same autoimmune process can attack the small airways in the lungs, causing something called bronchiolitis obliterans. It leads to irreversible scarring and lung function decline. It's often the ultimate cause of death.
Wow. A blistering skin and mouth disease leading to fatal lung failure. That really hammers home the systemic nature of these syndromes.
It absolutely does.
Okay, before we wrap up, maybe just quickly touch on how tumors can mess with blood counts, specifically making too many red blood cells.
Right, paraneoplastic polycythemia. Simple concept. The tumor makes too much erythropoietin, EPO, which is the hormone that stimulates red blood cell production.
And which tumors are known culprits for this?
Mostly renal cell carcinoma kidney cancer, which makes sense as the kidneys normally make EPO, but also pheochromocytoma, hemangioblastoma, and hepatocellular carcinoma, or liver cancer.
Yeah, the kidney cancer link seems logical. The tumor is basically exploiting the machinery that's already there.
Exactly. It hijacks the local production line, floods the system with EPO, and you get too many red cells. That can make the blood thick, viscous, raising the risk of clots, stroke.
This whole discussion really drives home that cancer isn't just a lump. It's a systemic disease right from the get-go, isn't it? Sending out these signals, these paraneoplastic effects.
Absolutely. PNS are like the tumor's long-distance communication network revealed. And understanding these specific, sometimes counterintuitive patterns, like why rapid ACTH doesn't cause the classic Cushing's look, or why weakness starting in the legs points one way, LEMS, and eye drooping points another, MG, that gives clinicians a huge diagnostic advantage. It can lead to finding the cancer much earlier.
Definitely provides a powerful diagnostic lens. Thanks so much for walking us through all of this complex biology.
My pleasure.
So here's something to think about as we finish. We've seen how tumors can hijack hormone production, turn the immune system against the body, mimic other diseases entirely. If they can do all that, create these very specific, sometimes dramatic syndromes, what else might they be doing? What other biological systems could they be influencing, maybe more subtly, in ways we just haven't labeled as paraneoplastic yet? The syndromes you know about might just be the tip of the iceberg when it comes to the tumor's systemic sabotage.